Hi, this is Bob Harrington on Medscape Cardiology and theheart.org. Over the course of the last few years, we've tried to have discussions with people doing work in the area of cardiovascular medicine, but more broadly, healthcare generally, that's touching upon topical issues. We've had some discussion in the past on this show about big data and what that might mean for you, how to think about genomics in cardiovascular health. Today, what I'd like to do is explore the intersection of big data and precision medicine. These are two phrases we hear a lot about. We hear it in the lay press. We see it in the medical literature. And what I really want to approach today is maybe on three components. One is definitional, and get one of our expert guests to talk about the concepts of precision medicine and big data. And secondly, how they see computational methods, analytics really playing a major role today in clinical research and clinical medicine. And then finally, some insight from their own works about what we all might expect in these areas in the future. So today, I'm really privileged and honored to have a friend and colleague as our guest, and he is Atul Butte. Atul is the director of the Institute of Computational Health Sciences and a professor of pediatrics at the University of California, San Francisco. Atul, thanks for joining us here today on Medscape Cardiology.
Thanks for having me. It's a real pleasure to be here.
Atul, you continue to amaze me as I follow you through the literature and maybe where I see you most, which is in the Twitter sphere of being somebody who is really at the cutting edge of what I'll call precision medicine and the use of computational methods in investigation. Understanding that we have a clinical audience largely on Medscape, can you define a few things for us? What should we be thinking about when we hear the phrase precision medicine?
Obviously, a lot of people are using that phrase all the way up to the President of the United States. Not everyone has the same definition, let's put it that way. But to me, precision medicine means the customization of healthcare for an individual based on the measurements that we get from that individual, but also using the learning and the data and the experience that we've gotten from everyone else, the rest of the population. So it's not just about, you, or me, my molecules and my measurements, my DNA, for example, but it's also about what have we learned from everyone else that we've ever taken care of before, all the measurements of molecules from everyone else. In some ways, it's a subtlety between personalized medicine, which people think is just about you, and precision medicine, which means learning from everyone and applying it to you. It's a broad definition, but obviously you need a lot of data collected on everyone else. What are the drugs we're ordering? How do they work? What are the molecules that we're able to measure? And then bring it all to bear with useful tools in that one exam room when the doc is taking care of the patient.
You know what I love about your definition is that you've included two things that I think about a lot, one of which I'll call a dichotomy, in that you're either practicing population-level medicine or you're practicing personalized medicine. I love your definition because you're bringing together both of those pieces, and maybe we can get you to comment on the population side. On the other side, what you're really saying is that we need to create a set of tools to help the clinician who is interacting with that patient at the point of care. I'm also guessing that you're thinking that you want to develop a set of tools for our patients and for individuals. So maybe take the pop health question first and then morph into the tools question.
I also agree. There is this dichotomy, it could be a false dichotomy, where precision medicine is seen as maybe the opposite of public health. I really think precision medicine can only be truly practiced if we actually have organized our populational or public health. But there is this dichotomy, especially on the costs of this type of delivery, right? People seem to think that precision medicine is going to be expensive. What we're trying to get to, though, is a story, a narrative about how precision medicine will save money in the end. Because it's not just about adding things to medicine. Maybe it's removing things from medical practice that we've learned from the data really don't seem to work. So I think these two concepts of precision medicine and population or public health really do come hand in hand. Now, you also asked about the apps. So you're right. I mean, data by itself, data sitting there does nothing, right? We have to have data in motion. That's really how we kind of generate voltage here in medicine. And when the data is in motion, whether it's apps that are being delivered to the docs maybe before the patients come into the exam room, or during that encounter, or maybe after, but certainly apps delivered to the patient so they are able to take care of themselves better between visits with physicians.
Certainly, one of the things I've loved that you guys are doing up at UCSF is the Healthy Hearts program, where there is that attempt to reach the patients in our communities directly to be able to extract information and put it to use from both an aggregated population way, but also allowing you to dig down deep about what's specific about that individual. A lot of the conversation we're having, Atul, really wraps around this notion of big data and what we know about you, your molecules, your genes, maybe your social media presence, your neighborhood, the environment in which you're exposed. How are we possibly going to make sense of all of this? Give the clinician who's practicing every day some sense of what people like you are doing in your research group to really harness the data. Data in motion, I love that phrase. I'm going to steal it from you.
I've used data as a moving thing, data as a frozen thing. You got to thaw out the data to release knowledge. I mean, there are a lot of these analogies, but what is this thing that we're talking about anyway? Big data. Obviously, we're talking about gigabytes and terabytes, so there's a storage aspect of data. We in medicine, we can talk about our data being big, but you and I both know, being here in Silicon Valley, our neighboring companies have much more data than we do in our healthcare institutions, like the Facebooks and the Googles and the Apples and all the rest around us. They will always trump us in some ways in terms of size on a hard disk. But our data is complicated, and it's traditionally not been looked at before. We do obviously now record a lot of measurements from our patients in the clinical exams and the lab tests. We record now what we're doing to our patients, what we've ordered, what's been dispensed. But there's more to it than just that. There's the imaging data from pathology, from radiology, and, of course, like you're saying, all the data that patients collect on themselves. You go make a restaurant reservation using OpenTable. Well, actually, what kind of restaurant are you going to? A healthy one or not so healthy one? Maybe that's relevant to your health. Obviously, your wearables, if you have them, like your Fitbits and Jawbone and Apple Watches that are tracking steps, those are useful. And increasingly, I think patients are going to be getting more advice through these types of devices than they're getting from us, encounter-based approach. One example I talk about a lot, I myself have been using Fitbit for almost 3 years now, but I started because I saw my weight exploding. I reached 247 pounds, and I had to fix that before I hit 250. That was a kind of weird threshold for me. I weigh myself every morning now. I know we don't always tell patients to do that, but this is what I'm doing. I record everything I eat, and I've lost 50 pounds. But what's funny about this story is my own doctor, and I'm not going to say who my doctor is. I'm not even going to say which health system they're in. They're not in yours, and they're not in mine, so there are only a few others, actually. But they literally, in the newspaper, they spent $1 billion on their electronic health record system, which also will be nameless. Everyone can guess which one that one is. $1 billion, but their $1 billion system doesn't talk to my $40 gadget because they're collecting one kind of big data, and my personal data is living in another data ocean or a lake or a puddle, and these two don't talk to each other. Data has this characteristic of sometimes getting stuck in silos, and if we don't really make it in motion to people who can give advice about it, we have this threat of patients actually cutting us out of the loop. But big data is about all of these types of streams of data. Now, let's bring it back to the clinician for a second. A lot of clinicians get worried. How am I going to deal with, let's say, 6 billion DNA base pairs in a 15-minute encounter? Technically, I trained as an endocrinologist. How was I able to deal with glucometer data in the exam room? Those were painful enough to download. There is one kind of doctor that actually today is able to look at a gigabyte of data in 5 minutes and actually render a diagnosis today. And they're actually radiologists, right? So a radiologist looking at a spiral CT or cardiac MRI, it's about a gigabyte of data, but they don't look at the data with ones and zeros, right? They have images, they have visualization and 3D. And that's what it's going to be like for most clinicians 5 or 10 years from now, that these complex streams of data, these complex amounts of data will be seen in some kind of visualization, some kind of tool that you're going to use during the encounter. Now, today's most electronic health record systems, I think most doctors use them after the encounter to document what they've done. I think we're going to be changing that mindset to use them during the encounter, not just to order the meds, but even maybe to get advice or even just to synthesize what's going on with that patient in front of them. So that's a long answer, but I think that's where I see it moving with big data.
No, it's a great answer. The visualization aspect, I think, is going to be both important and intriguing for clinicians, and your radiology example is spot on. I had a conversation earlier this week with a young pediatric cardiac intensivist who is interested in the visualization of physiologic data. And so I asked the question, Atul, I said, how much physiologic monitoring data does the typical pediatric ICU patient produce? He said, in the average stay of about 5 to 7 days in the pediatric ICU, they generate a couple terabytes of data. And you go, oh, my God, that's extraordinary. But then he jumped right into this notion of, but you can't think about it like you think about the current electronic health record. You have to do just what you said, Atul, which is start to get your mind around how we might approach the visualization of that physiologic data and the visualization in a way that's aggregated with other data so that you can begin to understand the patterns that might be particularly important to that particular patient.
Exactly. No one ever is going to think that physicians are going to figure this all out manually. There have to be more computational tools involved. Even the monitor traces now. We have alerts in the ICU setting. Now, that's the downside of a lot of this kind of automated type of analysis, where sometimes we build these tools, we think they're going to do well, but then they're alarming too frequently. So people ignore alarms. They ignore some of these computational tools that we think are going to help them. So we have to be a lot more intelligent about building the next generation of decision support tool that it doesn't just alarm because of legal reasons, but to actually be helpful to a physician.
A few months ago, I had a conversation on this show with your colleague, Bob Wachter, and his book about the digital doctor. And one of the best anecdotes that he tells is talking to an intensive care nurse. And he asked them, how do you learn to decipher the monitors? And she said, the thing I pay attention to is when they're not going off. When there's an absence of beeping, then I really get worried. And so it is this notion that we're going to have to retrain ourselves as providers about different ways of hearing the data, seeing the data, visualizing the patterns in the data. I've been fascinated by the work that you're doing, and I think our listeners will as well. Why don't you talk a little bit about what you do in your lab, and then maybe tie that into what you're doing in the UC system, because you really have a big role, not just at UCSF, but really thinking about data across the UC system, which is an enormous healthcare system.
Sure. So I'll answer it two ways. I'll first talk about my lab. Obviously, I launched my lab at Stanford and then just moved to UCSF a year ago. And I'll talk about one type of particular big data first, and that's public or open data. So I'm a big fan of big open data. What does that mean? Well, many scientists now, when they study particular conditions, let's say heart failure or diabetes, relevant to your audience here, if they use these kind of molecular tools, it's amazing. The top tier journals, the NIH, the Wellcome Trust, some of these funding agencies, they make these scientists share this data on the internet for transparency and reproducibility. And it's amazing how much molecular data or human samples, they're de-identified, of course, but you can do an amazing amount of new research using publicly available data. So we've done a couple projects looking, again, related to this audience on type 2 diabetes, finding new therapeutic targets. Just by putting more than 100 of these kind of data sets together, we start to realize that there's the same receptor showing up again and again. Maybe we can design a drug against those receptors. We've done that kind of work. A newer type of data that's becoming public or open is in clinical trials data. Because that same push, that same kind of mandate and sharing system we've had in the molecular world is now moving towards the clinical world, especially around clinical trials. And that in particular, I think we've seen a lot of pushback. There's this whole meme about research parasitism. Some clinical researchers don't want to share their data. They call people like me research parasites. That's fine. I'm happy to be a research parasite if that's what they call me. But I think in terms of transparency and reproducibility, we're going to get more clinical trials data released to the public. So we're learning how to do reanalysis and meta-analyses and things like that around this type of data. I happen to run a website where we give out raw clinical trials data to the public. So we're getting some practice there. The new fun thing I'm doing in the University of California is actually even beyond UCSF. They gave me an appointment at something called the University of California Office of the President. So for the listeners that don't know, University of California has 10 campuses, 5 medical, 5 non-medical, and then we have the Office of the President. So it's kind of like the 11th site. All 5 of our UC health systems, so it's UCLA, UCSF, Irvine, Davis, and San Diego, all under one umbrella that we call UC Health. We have cooperation across these 5. We have biweekly calls from the Clinical and Translational Science Award programs. We have consistency between IRBs. So if one approves an IRB, the others approve it rapidly on contracting. And so the new fun thing I get to do now is build out the common data warehouse, the common clinical data warehouse for all the electronic medical record data we're collecting on every patient in the University of California. And at last count, that's about 14.5 million patients have received some care in the University of California. And we have one database now with all the clinical data on these 14 million. Of course, it's under lock and key at a very secure data center. We are aware about breaches and security and privacy and all that. But the idea now is to learn from all 5 of these centers. Take anything in medicine. Maybe 3 of the centers are doing something better than the other 2. Let's learn from the 3, teach the other 2, and just keep rotating it. I think this is what they call a learning healthcare system. So we're going to use this data to help build out this learning healthcare system within the University of California.
Yeah, that's really extraordinary. And the other great thing is, I'm a still relative newcomer to California at almost 4 years, but the diversity of the population is extraordinary. And I suspect that that's going to be one of the real advantages of the UC system, is that the diversity of the California data really does mirror the diversity of the United States.
Perhaps it mirrors the diversity of the entire world. There are a lot of people who are not from California actually in California. We do capture the world's population in some way, bringing it full circle back to precision medicine. We're going to need to learn about the whole world's population so that we can help take care of every one patient individually.
Yeah, no, I think that's exactly right. And it's that notion, as we've talked about throughout the 20 minutes, of having that population-level data and having 14 million individuals within a common data set really allows you to think, to really hone in on what might be precision medicine. Atul, you've also brought up a couple of topics we're not going to cover today, but I absolutely would love to have you back to discuss, one of which is something that both patients and providers worry about, which is security of the data.
I'm happy to join you anytime.
Thanks, Atul. Well, this has been a really terrific discussion covering a wide range of topics around the general category of precision medicine and big data. My guest today has been Atul Butte, the director of the Institute of Computational Health Sciences and a professor of pediatrics at UCSF. Atul, as always, I appreciate your time and just love the things that you're doing. So thanks for joining us here on Medscape Cardiology.
Thank you again.